of Hospital Sisters Health System Sleep Centers in the Eastern Wisconsin Division. I also serve on the faculty at Fox Valley Technical College in their neurodiagnostics program, teaching polysomnography, and I am the president of the Wisconsin Sleep Society. We're going to talk a little bit about requirements for positive airway pressure treatment as it relates to Medicare. I have no conflict of interest to report, and I want to include this disclaimer that I am not a Medicare expert by any means. I have over 30 years experience in sleep medicine, working in sleep centers. I don't work for Medicare. I would recommend that you consult your local Medicare determinations for different areas of the country as it relates to guidelines for CPAP coverage. Medicare is basically an interpretation of the guidelines. It depends who's approving the claim. The purpose of this talk is just to let you know what I find in my experience and to reinforce that documentation is necessary in order for CPAP to be covered for our Medicare patients. These are the objectives that I hope to accomplish in this presentation. Continuous positive airway pressure, as we all know, is a non-invasive technique that provides air pressure to hold the airway open via a mask, and the purpose is to prevent collapse of the oropharyngeal walls and obstruction of airflow during sleep, which occurs in obstructive sleep apnea. The AHI, or apnea-hypopnea index, is equal to the average number of vents out of each hour that the patient is having an apnea, and as you know, an apnea is defined as at least 10 seconds, or a hypopnea, and a hypopnea is defined as an abnormal event, also each lasting 10 seconds with at least a 30% reduction in respiratory effort or airflow as compared to baseline, and an associated 4% oxygen desat. The respiratory disturbance index is an equal to the number of respiratory disturbances per hour. The AHI and or RDI can be measured by any facility-based polysomnography test or by any of the types of home sleep apnea test monitors that I have listed here, as long as they're recording and measuring at least 3 channels. I should add here that we have had some Medicare claims denied when an REI is reported versus an RDI, even if the physician interpreting the sleep study made a disclaimer in his narrative report that the REI equates to the RDI. So it's important that your reporting system states the AHI and RDI and or RDI in order for Medicare to interpret that report for coverage. An in-person visit with a physician, physician's assistant, or nurse practitioner is required for initial coverage of the CPAP device in regards to Medicare. This is what we call the face-to-face visit. This should include any documentation of comorbidities that the patient has, symptoms that the patient is experiencing relating to the obstructive sleep apnea, excessive daytime sleepiness, snoring, witnessed apneas, etc., and the reason that the study is warranted for medical necessity. On the diagnostic sleep study, an apnea-hypopnea index of 15 or an apnea hypopnea index of 5 to 14 with documented excessive daytime sleepiness, impaired cognition, mood disorders, insomnia, hypertension, ischemic heart disease, or history of stroke is what is needed to qualify the patient for the CPAP device. And the PAP device must be issued to the patient within 1 year of the qualifying sleep study. So that's always a question that is asked, is when does a patient need to be retested? Or the CPAP device has to be ordered within 1 year of the qualifying sleep study. If it's past 1 year, the patient will need another sleep study. Once a patient is qualified for the CPAP device, based on their sleep study and their AHI, RDI, what is required for continued coverage for the CPAP is proof of compliance. Medicare does require that the patients are set up on a downloadable type of CPAP device where compliance can be proved and verified. The PAP device has to be used for 4 or more nights 70% of the time, and that equates to approximately 21 out of 30 nights use of 4 hours or more a night. This is what we refer to as standard compliance. Medicare requires the patient to meet a 30-day compliance within the first 90 days of obtaining the PAP device. So from the first day of setup, 30 days of that compliance minimum that I referred to in the last slide, 30 consecutive days of this, the patient has to be compliant within the first 90 days. So within 90 days, any of the 30 days, but they have to be consecutive days. They have to be wearing it at least 70% of the time. So if the patient does great with it for the first 30 days, but then struggles for the rest of the 90 days, they still would qualify and have continued coverage. But it has to be 30 days continuous within the 90 days, the first 90 days from when they were set up. An in-person visit with the physician, nurse practitioner, physician's assistant with documentation of adherence to the therapy and documentation that of improvement of their symptoms is also required for the continued coverage of the rental of the machine and purchase of supplies. So after the patient starts the therapy, 30 days compliance has to be proved within the first 90 days, and they have to have another face-to-face visit with the provider 31 to 90 days after initiation of the therapy. As I said before, Medicare does require that the CPAP machine that the patient is set up on has a downloadable capability. This is required for proof of compliance by downloading the PAP device and producing a report. Many of these systems are web-based now, where compliance can be viewed by the day, by the month, by a longer period of time, and also give additional information that's helpful, like AHI, improvement with the AHI, leak value, etc. Patients who do not meet the minimum standard compliance within the first 90 days would require another in-person visit with their treating provider. At the time of this visit, they talk about what were the roadblocks to adhering to the therapy, what is it that they don't like about it, why didn't it work, and if they want to continue with the therapy would require another facility-based sleep study. The facility-based sleep study can be a diagnostic study, it can be a titration study, it can be a split night study. home sleep apnea test will not qualify a patient after a compliance failure. So if the patient struggles with the therapy and is not compliant and Medicare says you can't continue to have this therapy and the therapy is returned, the patients need another study, a face-to-face visit and another study in order to get the CPAP and try using it again. And documentation is required as to why it didn't work, why it's going to work this time, that sort of thing. Also, a titration study is really indicated in these situations. The patient, struggled with the therapy, didn't do well with it. You don't have to do another diagnostic. You can just go right to the titration because we've already proved that the patient has sleep apnea. It's important that we monitor the patient's use of this PAP device right away. If the patient isn't using the PAP device in the first week after the setup, it needs to be addressed. What is happening? Is it leaking a lot? Is the mask uncomfortable? Why aren't you wearing it? The patient also needs to be aware that if they don't comply, they'll require a new sleep study in order to requalify and continue using the unit. As I said before, compliance is defined as wearing it 70% of the time in a 30-day period of the first 90 days after setup. So the patient needs to understand that if they put it off and don't make a successful attempt to use the device until the last couple weeks of the 90-day trial, no matter how much they wear it or how much they like it or how well it works, they are not going to achieve the full 21 out of the 30 days with at least 4 hours of use, and their PAP rental and supplies will not be paid for. In order for CPAP to work effectively, it's necessary to replace the disposable supplies on a regular basis. The cushions, the head straps, the hose, the humidifier chamber, all that stuff. The PAP treatment loses its effectiveness as the equipment isn't new anymore and starts to break down and wear out. Cleaning per the manufacturer's manual will extend the use of most disposable supplies, and improper care and lack of cleaning will cause the disposables to break down and therefore not last the suggested replacement time frame. According to experts, 7 out of 10 PAP patients say they sleep better after getting replacement supplies. And that only makes sense. We know that sometimes when the patients come in for the sleep study and they have an old cushion, we'll replace it, put a new cushion on, and the leak is much more acceptable. Therefore, the patient sleeps better. 1 in 3 patients say they get more sleep after replacing their supplies. And there are 2 main reasons why you need to replace your PAP equipment regularly. It's to avoid bacteria and for it to function appropriately. Documentation of the reason the new replacements is required for Medicare. Reasons can include but aren't limited to the following. Well, the equipment is wearing out, it's not sealing well, the headgear is stretched out, the tubing isn't fitting well on the humidifier chamber. So again, Medicare is big on documentation. Document. I think if the providers say what they're thinking, we know the logical thing that is to occur, but the more that it can be in the documentation, the easier it'll get for Medicare to prove that it is medically necessary for the patient to have this equipment or replacements. This is a schedule of how often Medicare allows replacement of disposables. Every month, the patient can get a new mask cushion and or nasal pillows for the full face mask, or they can get 2 nasal cushions a month or 2 nasal pillows a month and 2 of each CPAP filter. Every 3 months, they can get the mask frame, that does not include the headgear, and a new CPAP tubing. But they have to wait every 6 months to get a new headgear, and the headgear is, to me, one of the things that wears out the quickest, but they can only get 2 headgears per year, and every 6 months. A chin strap, if applicable, and then the chamber for the humidifier also is on a replacement schedule for every 6 months. The reasonable amount of time we can expect a PAP machine to function properly is 5 years. If the patient's device is 5 years old, Medicare will require an in-person evaluation with the provider, documenting the patient's continued use and the benefit of the therapy, and also a new prescription. What about switching from CPAP to BiPAP and qualifying for BiPAP? This is something that comes up quite frequently in the sleep center. CPAP or AutoPAP have to be tried and proven ineffective based on either A, trial in the lab, or B, a trial in the patient's home. So ineffective therapy is considered to be failure to meet therapeutic goals of the CPAP, AutoPAP during the titration portion of a facility-based test or during the home test using optimal therapy, meaning it has to have a good sealing mask, and the therapy settings have to be appropriate enough to overcome the apnea. But if we can show during the lab we had the patient on CPAP, A, they weren't tolerating it, maybe they said it was too hard to breathe against, and we switched to BiPAP and then they were able to wear it, or they tried CPAP at home and it didn't work out, but that's also justification to switch to BiPAP. So all that is required to switch from a CPAP or AutoPAP to BiPAP is it has to be tried and proven ineffective either in the lab or in the patient's home, and that has to be documented. And the ineffective treatment has to be on adequate therapy settings with adequate mask seal, etc. It is possible to qualify for a BiPAP device with the diagnosis of hypoventilation if the following criteria are met. This is a criteria needed to qualify somebody for BiPAP under the hypoventilation diagnosis. And notice in the green bold text I have and or, because these guidelines require this, and this or this. So sometimes it's a combination of these guidelines that's needed in order to qualify the patient under the hypoventilation diagnosis. This comes into play sometimes when we have patients with hypoventilation, respiratory failure in the hospital, very large patients, and then they go home from the hospital. They were using either a BiPAP or a RAD device in the hospital, and they go home and the provider would like them to have the BiPAP to use at home. In order for them to get qualified, this is what is needed. First of all, initial blood gases performed while awake and breathing. The patient's prescribed FiO2 is greater than or equal to 45 millimeters of mercury. Also, spirometry with these values, FEV1, FBC greater than or equal to 70% and FEV1 greater than or equal to 50% of predicted, and the initial blood gas done during sleep or immediately upon awakening and breathing the patient's prescribed FiO2 shows the patient's CO2 level worsened by greater than or equal to 7 millimeters of mercury compared to the original result. Or if you don't have that second blood gas, a facility-based polysomnography demonstrates O2 stats less than or equal to 88% for greater than or equal to 5 minutes of the night recording, and that's the whole recording, not 5 consecutive nights, out of a minimum recording time of 2 hours. And this has to be not caused by upper airway events such as the AHI. So the AHI, in other words, has to be less than 5 per hour. Patients with chronic obstructive pulmonary disease may also qualify for a BiPAP device by using the following criteria. Qualifying patients under the COPD diagnosis for BiPAP require arterial blood gases done while awake and breathing their prescribed FiO2, to have a CO2 level of greater than or equal to 52 millimeters of mercury, and sleep oximetry demonstrates oxygen desaturations less than 88% or equal to 88% for greater than or equal to 5 minutes of the night recording, and that's 5 minutes of the whole recording, does not have to be cumulative, out of a minimum of 2 hours recording time, while done breathing oxygen at 2 liters a minute or the patient's prescribed FiO2, whichever is higher. And prior to initiating therapy, obstructive sleep apnea and treatment with CPAP has been considered and ruled out. I just wanted to add here that it is difficult to qualify patients for BiPAP without a sleep study and those other guidelines. I mean, it's possible, but many of our COPDers have obstructive sleep apnea, so obstructive sleep apnea has to be considered and ruled out, treated with therapy before they would qualify. Qualifying patients for oxygen prescribed with their PAP device. The oxygen level has to be 88% or less, and a qualifying secondary diagnosis, and obstructive sleep apnea cannot be the secondary diagnosis, or oxygen level less than or equal to 88% for at least 5 cumulative minutes during the titrated facility-based PSG. So they have to have an in-lab sleep study with a minimum of 2 hours recording time, and the patient must meet the following chronic stable conditions: nocturnal stationary oxygen qualification only. So we qualify these people by bringing them into the sleep lab for another titration study, and then they have to meet the oxygen level of less than 88% for 5 minutes out of a 2-hour recording time. Reason being, we want to prove that the OSA has been adequately treated with the right amount of PAP and such, and there's still a need for supplemental oxygen. Nocturnal oximetry for the purpose of oxygen reimbursement qualification can only be performed after optimal positive pressure settings have been determined and the beneficiary is using the device at those settings. Additionally, during the titration at optimal settings, the AHI RDI has to be reduced to less than or equal to 10 events per hour, or if it was less than 10 before we started, the AHI has to demonstrate a further reduction in the AHI RDI. And it is important to note that overnight oximetry performed as part of any kind of home sleep testing, oximetry recording is not eligible to qualify for reimbursement for home oxygen and oxygen equipment. Patients diagnosed with sleep apnea may still qualify via the awake and resting, awake and exercise pathways. So if they did a 6-minute walk and their oxygen level dropped to a level that would qualify them, they still may have oxygen at home under one of those other pathways. And if they have oxygen at home by qualifying for one of these other pathways and they have the PAP device, they by all means can use it at night also with their PAP. They don't need another sleep study to qualify them for that. These are the two codes that define the different types of respiratory assist or RAD devices. EO470 is your regular BiPAP S that has two pressures, one on the inhalation, one on the exhalation, but do not have the backup rate feature. And then EO471 is a respiratory assist device with bi-level pressures and a backup rate. These are the types of devices that include the backup rate or would fall under the EO471 category. IVAPs manufactured by ResMed, intelligent volume assured pressure support, meant to assist and give a set amount of volume, breath by breath for the patient. The Respironics counterpart to that is the AVAPS, average volume assured pressure support, or we would have the adaptive servo ventilations, auto SV by Respironics, and VPAP Adapt by ResMed, which are used to treat central sleep apnea, where the periods where the patient isn't breathing enough, the backup rate kicks in and gives volume of air to get them through those periods. Of course, during these situations, the qualifying feature here for Medicare is greater than 50% of all the respiratory events scored have to be central in nature. So it is important that physicians, when interpreting the sleep study in their narrative, describe the types of hypopneas. If the hypopneas are majority central, they should say that in the narrative. These may be situations where we in sleep labs have to score central and obstructive hypopneas in order to meet this greater than 50% qualification. But it is important that it is documented as much as possible on the numeric report or the narrative report in order for the patient to qualify for one of these devices. And again, here RADs are types of non-invasive ventilation, and treatment of RAD is not covered with the primary diagnosis of obstructive sleep apnea. Here are some references for you. Again, I recommend that you check your local determination for Medicare guidelines in the area in which you live, and just keep up to date on all the guidelines, because as we know, they're changing all the time, and there's new things, information coming on the scene. So keep in touch with your home care providers. They're usually very up on this information, and we can work together to get the patient the type of therapy that is needed to serve them for the type of disease process that they have. So I hope you enjoyed it. Thank you very much. Okay, and we're back. Give me a moment here to look at the questions. I agree, the headgear should be every 3 months. Yes, the headgear stretches out. It's the first thing to go usually, but it somehow Medicare doesn't feel that the patient qualifies for 6 months to get a new headgear. I did want to add that just consulting my notes here, central guidelines for RAD or for central sleep apnea or complex sleep apnea. There are ways for the IVAPs and AVAPs that a patient can qualify with a neuromuscular diagnosis like ALS or something like that. Muscular dystrophy, those kind of situations where the patient needs assistance to the breathing. So do we have any other questions here? Otherwise, anybody can certainly chime in. Contact me by email if you have other questions. I'd be happy to answer it to you, marla.vanlannon@gmail.com. And if you would like to put something in the, we do have one question. Can the second in-person appointment cannot be with an RRT? No, it cannot. It has to be with a nurse practitioner, physician's assistant. Anybody wants to add in the chat? Also, we have just a few minutes here, and then we're going to start up with Dr. Nusrat's presentation on home sleep study, but it's really been an enjoyable day. And if you want to add in the chat any kind of comments for us on what you thought of our first ever video conference, we appreciate that feedback also. I have another question. Can the 31 to 90 day be telemedicine or a video? Yes, it can be a telemedicine visit. So as long as it is by a nurse practitioner, physician's assistant, or sleep medicine provider. Any other questions, comments for us? Right now, due to COVID, of course, telemedicine has become a great big part of those follow-up visits that are so ever important for Medicare to approve CPAP for a patient. I think the biggest thing is also, if patients fail on the CPAP device, they had it, they tried it once, they gave up on it. The guideline states that we can bring them back into the lab for all-night titration. We don't have to reprove that they have sleep apnea again, and home sleep testing is not appropriate in those situations. You want to get them back in the lab where it only makes sense, so that we can make sure they're getting the right pressure, they're getting the right mask fit, those types of things, so that they can be successful again. All right. So I think we'll go ahead and move on to our next presentation. I thank you all very much for your time and attention today. This has been very exciting for us all. Our last presentation of the day, but I do have to add, please stick around After the last presentation in this room, we're going to do some door prizes and some closing remarks with some housekeeping items. So please stick around after the last talk. It's a chance to win some fun prizes. So our last speaker is a colleague of mine. He is been a major part of through this pandemic, covering the ICUs on 2 campuses here in Green Bay, Wisconsin, where I live, at our 2 sister hospitals in town. He's also a very good sleep medicine physician. He is our medical director of the HSHS Sleep Center at St. Vincent Hospital, and he is reading all of our sleep studies in between his spare time. So he's a very busy guy, has to be commended because he's been very, very busy this last year and a half with COVID, helping those patients tremendously. So his name is Dr. Musab Nusrat, and he's going to talk to us about home sleep testing. Bear with me here a minute. I see we don't have any audio for that video, so let me troubleshoot this and we will be right back with you momentarily.
Apnea evaluations can be performed.
I think I have it. Here we go. Home sleep apnea testing. Dr. Musab Nusrat.
Hello, thank you everybody for your attendance. My name is Musab Nusrat. I'm a pulmonary critical care and sleep specialist. I'm so thankful for the invitation to participate in this sleep conference. Today we're going to talk about home sleep apnea testing, and during this talk we're going to describe the sleep apnea testing classification. We're going to try to identify, or will identify, the home sleep apnea testing indications and contraindications. Also, we're going to talk about the automatic positive airway pressure devices indications and contraindications. As an introduction, obstructive sleep apnea is a disorder that's characterized by obstructive apneas, hypopneas, and or respiratory effort-related arousals caused by repetitive collapse of the upper airway during sleep. Diagnostic assessment and treatment for this disorder have been based on the standard polysomnogram, which is an attended recording of sleep stage, respiratory, and other parameters. and the polysomnogram continued to be the accepted diagnostic method in most clinical and research settings. However, sleep apnea evaluations can be performed more quickly and more conveniently and at a lower risk by an attended recording of a fewer parameters than recorded on polysomnogram, which can also lead to a wide or increase the rate of diagnosis of the sleep disorder breathing. To talk about the size of the obstructive sleep apnea problem, we need to know the prevalence of this disorder in the community. In North America, it's estimated that around, if you're gonna use the crude definition of AHI more than 5 events per hour, it's estimated that in North America there is approximately 15 to 30% prevalence in males and around 10 to 15% in females have obstructive sleep apnea. If you're going to use a more specific definition of the sleep apnea, which is AHI more than 5 events per hour plus symptoms, or AHI more than 15 events per hour, the estimated prevalence is approximately 15% in males and 5% in females. Globally, the problem is also, we're not alone in this world, and this problem is estimated that around more than 9 million or 936 million people worldwide has mild to severe obstructive sleep apnea, and a little bit less than half of that has moderate to severe obstructive sleep apnea between the ages of 30 to 69 years of age. Why sleep apnea is prevalent and why the prevalence is increasing. As we all know, the number one risk factor for obstructive sleep apnea is obesity. And as we can see from this slide that was taken from CDC in 1993, you could see the maps with obesity prevalence of around like less than 19% in most of the states in the United States, with the highest percentage that time of 15 to 20 to 19% of BMI more than 30. Seven years later, in 2010, as you can tell, the prevalence of obesity increased significantly all over the United States, with some states, including Wisconsin, has 25 to 29% of their population has BMI more than 30, which increases the risk of obstructive sleep apnea. People also live longer, and with increased age, it was found that obstructive sleep apnea also increases in prevalence, as you can tell from the slide that plots the age in years and the prevalence of AHI more than 15 and percentage. You can tell it's the most linear relationship between the age after the 35 years of age until 85 years of age, with around 25% of people more than 85 years of age has AHI of more than 15 events per hour. With increasing the age, and with advances in the medicine, the people live longer, and they live longer with comorbidities that increases the risk of obstructive sleep apneas. So other risk factors for obstructive sleep apneas, including obesity of a class 2 and more, especially with BMI more than 35. People with congestive heart failure also at higher risk, with AFib, refractory hypertension, diabetes, strokes, arrhythmias, especially nocturnal arrhythmias, pulmonary hypertension population, also high risk, diving populations, and pediatric surgery patients. All of these are people that high risk for obstructive sleep apneas. Of course, with increasing the awareness of the problem, the testing of the obstructive sleep apnea increases, and as does the cost for the test. And it seems to be, as you can tell from this slide that was taken from the CMS, the test rate increases gradually over the years, and also the cost of the testing increases, which seems to be increases more than just the number of the test. We'll talk briefly about the history of polysomnography and the history of the sleep scoring in general. So back in 1937, this group of scientists described that different stages of sleep were reflected in changes of the EEG. Around less than 10 years later, these two scientists also identified the rapid eye movements during the sleep, and start the awareness of the that could be different stages of sleep at that time. And 4 years later, there was a description of a relationship between the eye movements, body motility, and dream as well. And not until around 10 years later, which is 1968, when these two scientists described the first standard sleep scoring techniques, and it was continued until 2007, when American Academy of Sleep Medicine published the first manual for scoring of the sleep and associated events, and continued to publish a manual for the scoring of sleep and associated events periodically, with the most recent publication of that was in 2020, January 2020, of version 2.6. We're going to talk about the sleep apnea testing classification. So there was like 4 types of sleep apnea testing classifications that were defined. Type 1, which is the standard of care, it's in the center, attended overnight polysomnography. Type 2, record the same variables like type 1, but with unattended. Type 3, which evaluate 4 physiologic parameters but not sleep parameters. So in this type, or in this way to monitor the sleep disorders, there won't be sleep stages, but instead they'll record the parameters that will indicate respiratory events. This device, there will be record of the respiratory movement and airflow. There will be record of heart rate, arterial oxygen saturation, snoring, and position. Type 4 devices evaluate 1 or 2 parameters only, for example, saturations and airflow. So what is polysomnography? So polysomnography is a simultaneous recording of multiple physiologic signals during sleep, including electroencephalogram, which includes central, occipital, and frontal leads recording, electromyogram, which including chin, tibialis as well, electroelectrogram to record the activities of the eyes during sleep, and so to identify the REM sleep stage, which usually record both right and left eye electroculograms. Electrocardiograms also at least 1 lead of EKG recording to identify different kind of arrhythmias. There will be snoring microphone, nasal or airflow, including thermistor and pressure, signals, thoracic effort, abdominal effort, oxygen saturation, body positions, and video recording as well will be included in polysomnography. As you can tell, this is an extensive study that require a personal attending the study and different kind of leads and attachments to the patient. Unattended home sleep apnea testing, type 3 device. So it measures or records the nasal oral airflow, thermistor, and pressure. It also records thoracic abdominal effort. It records the oxygen saturation, pulse rate, snoring microphone, and body positions can be also recorded. So is this like a new concept? Is home sleep test is a new concept? So there have been studies that goes back to 1980. For example, this study that was published in a Raven Press compared the standard method that time, which is the standard polysomnograms or polysomnography, to the portable device that uses 4 channels, as you can see in this figure, and with a small number of patients that they recorded their sleep events using this device at home. Then they brought them back to the sleep lab, and they record their they have polysomnography. In the same time, there was a recording of their portable device again during the study. So basically, each subject there were like 11 of them. Each subject has 2 portable sleep studies, one at home and one in the lab, and polysomnography, and they found no difference, no big difference between the portable recording and the home and the lab sleep studies. This other study was published in July 1990 in Southern Medical Journal as well, and they tested or they examined 67 patients that were referred to their sleep center at that time, and they were examining them with the home with a device designed to be used at home to diagnose obstructive sleep apnea, and they directly compared that data to the data obtained from a standard polysomnography. The home device that time recorded nasal oral airflow, chest wall movement, cardiac rhythm, and blood oxygen saturation, and there were no significant difference in the number of disordered breathing events between the 2 methods or the 2 systems. And the portable device was found to have a sensitivity of 95% and a specificity of 96%. Also in this study, this is another old study that they initially compared, one from the initial studies that compared or they tried the treatment of obstructive sleep apnea as an outpatient or home, what we called home titrations. In this study, they selected 11 patients who were diagnosed with severe obstructive sleep apneas using portable unattended sleep apnea recording with average AHI around 41 events per hour, plus minus, with a standard deviation of 15.5. These patients, they were like phone interviews. They started with treating them with nasal CPAP at 8 cmH2O. Initially, actually, between 5 to 7.5 cmH2O. Then they will call them at home. Then they will increase the pressures by 2.5 centimeter of water until the patient's symptoms disappears and snoring disappears. Then they will take them back and they test them with the portable sleep studies were on their devices, and they found that in all of these patients, the sleep apnea or their respiratory events were normalized to less than 5 in all of these subjects. So home titration or automatic portable or automatic portable pressures devices are also effective and important according to this study. In 1994, and the recommendations was that the standard polysomnography is the accepted test for the diagnosis and determination of severity and treatment of obstructive sleep apnea. And they talked about the unattended portable recording for the assessment of obstructive sleep apnea as an acceptable alternative only in certain situations. For example, for patients with severe clinical symptoms that are indicative of diagnosis of obstructive sleep apneas, but when the initiation of treatment is urgent and the standard polysomnography is not readily available. So in these, so they say standard polysomnography is the ideal method or the accepted method. They accepted the polysomnography that time only almost, except in patients who they have significant severe symptoms. But the polysomnography, and they need to be treated urgently, and the polysomnography is not urgently available. Also for patients unable to be studied in the sleep lab. So some of the patients, because the immobility or the critical illness they have, that we couldn't bring them to spend the night in the sleep lab, they allowed to use portable sleep studies that time. The other, or the third indication is for follow-up when the diagnosis has been established by the polysomnography, and they use other ways of treatment of obstructive sleep apnea. So basically to evaluate the response to therapy, including the weight loss therapy, surgery, medications, or even CPAP therapy. There was another practice guidelines that was published by American Academy of Sleep Medicine in sleep medicine in July 2007. And there was more, so, and they recommended that they mentioned about the indications of portable monitoring devices, and before they allowed that the portable sleep studies can be done to the patients, that these sleep studies, that the evaluations or for like portable monitoring for the diagnosis of obstructive sleep apnea should be performed only in conjunction with a comprehensive sleep evaluations. So, and this needs to be done by a sleep medicine expert before you could even think about or indicate about doing the portable sleep studies. The patient needs to be evaluated by a sleep expert personnel who's sleep board certified or at least board eligible before or ordering the sleep study. And the guidelines from the American Academy of Sleep Medicine allowed or mentioned, talked about the indications of the portable sleep studies, giving that the patient with suspected sleep apnea evaluated by the sleep expert, that portable monitoring devices may be used as an alternative to polysomnography for the diagnosis of obstructive sleep apnea in patients with high pretest probability of moderate to severe obstructive sleep apneas, and should be like is indicated for or can be used as an alternative for polysomnography in cases of moderate to severe obstructive sleep apneas and in case of simple sleep apneas, and not in the patients who have other comorbidities that will affect the accuracy of sleep apneas. These patients include severe pulmonary disease patients, neuromuscular disease, or patients with congestive heart failure as well. Portable sleep studies also, or portable monitoring devices, also not appropriate for diagnostic evaluations of obstructive sleep apneas in patients suspected of having other sleep disorders, including central sleep apneas, periodic limb movement disorders, insomnias, parasomnias, circadian rhythm disorders, or narcolepsies. Also, portable devices are not appropriate for general screening of asymptomatic patients as well. The other indication for portable, or the other indications per the guidelines for portable monitoring devices, is to diagnose in patients on whom in-lab polysomnography is not possible, like patients because of safety issues, or patients with critical illness that causes them. I mean, they cannot attend night sleep studies in the lab. The third indication is to monitor monitor the response to non-CPAP treatments therapy of obstructive sleep apneas, including oral appliances, upper airway surgery, and weight loss when the patient lost significant. Amount of weight. So why we are using the, so what's the advantage of the sleep apnea testing, especially that these are less precise and it carries low reimbursement. So the advantage is patient comfort and convenience. Of course, this is less leads, and patient will be sleeping at home, and less attachment and less monitoring to the patient. Also privacy and stuff. It has lower cost to the patient. The pay will be less for the patient, and especially with nowadays with increased the high co-insurance payments and increasing the deductibles, and the patient outcome appears not to be worsened with good program on appropriate patients. Also, there was like a good PAP adherence, and based on the objective ways of testing the quality of sleep, they all showed non-inferiority of the O2 devices than the regular CPAP. And some of the, in addition, some of the insurance, and a lot of insurance companies now mandating home sleep apnea testing because of the cost nowadays. And because of the importance of this, I mean, there are like multiple devices nowadays available in the market that can be used for portable or for home sleep apnea testing. There should be like a good or a standard of care, or a good ways to choose and to identify the adequacy or the adequate home devices that we should use for home sleep apnea testing. American Academy of Sleep Medicine considers an adequate device as one of the that has or incorporates a minimum of the following sensors. It should has at least a nasal pressure recording, and should have the device should also has chest, abdominal, respiratory inductance plethysmography, and also should use oxygen saturation devices to record the oxygen saturations. These are the minimum. If you can tell, this is the minimum indicators, that the minimum physiologic parameters needed to identify or to know or identify or quantify the respiratory events during sleep. Alternatively, devices that uses peripheral arterial tonometry or PAT, which indirectly detects respiratory events with oximetry, detects oxygen saturations, and actigraphy, are appropriate altogether and acceptable per AASM requirements as well. So what are the indications for home sleep apnea testing? And as we said from the guidelines, the indications is, or the most common indication for the home sleep apnea testing is the diagnostic evaluation for obstructive sleep apnea in patients with high pretest probability of moderate to severe uncomplicated obstructive sleep apnea. So if you see patients in the clinic with moderate to severe or with high pretest probability of moderate to severe obstructive sleep apnea, then you could consider, and he is otherwise healthy with no comorbidities, you should consider home sleep apnea testing. And also follow-up assessment of obstructive sleep apnea therapies, like patients who were diagnosed with obstructive sleep apneas and were started on treatment other than CPAP, and you wanted to identify if their treatments are effective or not. You could do portable sleep studies in that case. Also, in patient in home in-lab polysomnography not possible because of immobility, safety, or critical care illness, you can consider home or portable sleep apnea testing in that case as well. So what are the contraindications for home sleep apnea testing? Basically, anything that can affect or can affect the accuracy of the sleep apnea testing, or anything that can affect or can make the using the auto CPAP inadequate way of treating the sleep apnea. So patients with severe pulmonary diseases, because usually these patients don't need more than just correcting their respiratory events with the devices, and usually the accuracy of sleep apnea testing is not going to be accurate because the hypoxia as well during sleep. Patient with BMI more than 40 or morbidly obese patients, because a good percentage of these patients that will have a hypoventilation during sleep. Narcotic analgesic use patients, because it increases the risk of central sleep apnea. Patient with connective tissue disease, and right now it's phenomenal, because these patients, the failure of the study, of portable sleep study, would be high because the failure of the recording of the oxygen saturations. As we mentioned, neuromuscular disease patients, stroke patients, congestive heart failure patients. If for patients who are unable to cooperate, like dementia patients, and there would be problems of them putting the records and doing the sleep study, and the failure rate will be high as well. Asymptomatic patients, as well as we mentioned, individuals suspected of having other sleep disorders, because there will be no video recording and you won't know about the parasomnias, for example, and if they have other sleep-related disorders. Identifications of individuals working in safety and critical occupations, and this is mainly because of the so these patients are so people who are working in like in a school bus drivers or city bus drivers, they carry a higher risk, or pilots. These are high risk occupation that you want to make sure that these patients, they have or they don't have sleep apneas, because sometimes people you're afraid that you send somebody with portable device, for example, but they will use it to somebody else, and you will just record the sleep for somebody else, and you won't know, for example, because they're afraid that they lost their jobs and stuff. So you want to make sure that these patients really have or don't have sleep apneas. The recommendations to have these patients to have a sleep study in the lab. Pediatric populations also, these are inappropriate to use the home sleep studies to diagnose sleep apnea with. So after that, there was like a lot of questions about the home sleep apnea testing. Does it like adversely affect us the obstructive sleep apnea outcome? So diagnosing and treating sleep apnea as an outpatient, does it affect the outcome for sleep apneas? And to answer this questions, or to answer this question, we'll discuss this study, which is a multi-site randomized trial of portable sleep study and positive airway pressure authorization. Auto titration versus laboratory-based polysomnography for the diagnosis and treatment of obstructive sleep apnea. So in this study, they randomized and people between two arms. In the arm one, they basically did baseline lab polysomnography, and they did a split night sleep study. If they split to the AHI 15, those are who split, they will start them on CPAP treatment based on the split, the second half titration study. And those who did not reach the AHI 15, they will have a full night diagnostic polysomnography, and if they reach to the 15, they will come back for a full night lab PAP titration. The portable monitoring arm, they sent them with unattended home cardiopulmonary monitoring, and for those who have AHI more than 15, they will send auto PAP or auto CPAP to them directly. And for those who did not reach the diagnostic threshold of 15 or more, they will have in-lab polysomnography. And for those who have 15 or reach to the threshold of 15, which is acceptable threshold for the study, they will have auto CPAP as well. So what's the results of the study? So at 3 months after 3 months, the PAP or CPAP usage was, which is the nightly time at the pressure giving, was higher at 4.7 plus minus 2.1 hours with the home study or auto CPAP versus 3.7 plus minus 2.4 for the lab population. The adherence as well percentage, which is defined as percentage of night used more than 4 hours use, was 62.8 plus minus 20.2% at home versus 49.4 plus minus 36.1% in the lab. The acceptance of PAP therapy, titration pressures, effective titrations, time to treatment, and Epworth Sleepiness score changed not different between the arms. The cost also was much less in the auto or in the home group versus the lab group. There was also non-inferiority of functional outcome in ambulatory management of obstructive sleep apneas, that the same way population of patients or the group of study like divided the same way, with around 148 people were tested in the lab and 148 people were tested at home, and there was no inferiority. They concluded that there is testing organ is not clinically inferior to the patients receiving standard and laboratory polysomnography. So they were about the same. There were multiple studies, also similar studies, that comparing the home sleep studies to the lab sleep studies and titrations at home versus titration in the lab, and there were no significant difference, and at least there was no inferiority between these studies. So auto PAP as good as CPAP titration in simple sleep apnea as well. And also there was like a equivalent to CPAP in efficacy. Like there are other studies that were using and comparing the auto CPAP versus CPAP titration and for the simple obstructive sleep apnea, and there was no difference between these methods of diagnosing and treating obstructive sleep apneas. So what are the contraindications for auto PAP or auto CPAP? We all should know about this because not every patient that even tested positive for polysomnography we should send them an auto CPAP. Some group of patients that they using auto CPAP or auto PAP is contraindications. So auto CPAP or auto PAP are contraindicated to diagnose obstructive sleep apnea instead of polysomnography. It's also relatively contraindicated in congestive heart failure patients because of tendency to develop central sleep apneas and change stocks breathing. Patients with significant lung disease as well, or severe lung disease like COPD patients and patients who are on oxygen, because again, these patients, they will be hypoxic and they will need more than just correcting their respiratory events. Obesity, hyperventilation syndrome patients who don't snore, central sleep apnea patients for the same reason that the auto CPAP is contraindicated. My last slide is to just kind of talk briefly about different devices available for home sleep apnea testing and contract comparison between them. I'm not going to talk much about this. It's just there's briefly, I mean, they're all effective, and there's some subtle differences between the cost and between the customer services in the 24 hours. And so, and WatchPat leads, for example, there will be a 24/7 customer service for the patients, and our sleep center here in Green Bay, we're going with WatchPat. The other devices has, I mean, the cost may be comparable, they're about the same in the cost, and the easiness of use, the easiest will be the WatchPat. ResMed Apnea Link is also easy. Philips Night One is also easy to use, and most of them are relatively easy to use. And giving the cost difference and how effective and how similar, I think there will be increased more and more usage of the portable devices instead of the in-lab polysomnography, especially with the insurance company pushing this way, knowing that for at least simple, uncomplicated sleep apnea patient, or at least for patients who have a pretest probabilities that's a high or moderate to high, for moderate obstructive sleep apnea, portable sleep study should be considered first. The disadvantage for portable sleep apneas is that, I mean, it's not accurate, so the false negative rate is relatively high. So patients who have negative portable sleep studies, and you think it's still a possibility, you should consider in-lab polysomnography, especially patients with high risk comorbidities or high risk jobs or occupations. The other disadvantage is the accuracy or the identification, because you send the device with the patient or with the personnel that there is no one-to-one watch, and this can be, I mean, especially for the high-risk jobs or occupations, you don't know if this device it's gonna be used for that patient or it's gonna be used for somebody else, because people sometimes worry or afraid they're gonna lose their jobs, and instead of wearing the device, they will get the device to their friends or somebody who is at much lower risk, and you will have a false negative results as well. This, I conclude my talk, and again, I thank you very much for your attendance, and thank you very much for your time and for the opportunity that you gave me to participate in this conference. Thank you.
Okay, I apologize. We had a few little video glitches and lags with that video, it seemed to. We tried to keep it going for you, but again, don't worry, it will be available for you on demand, and the PowerPoints also will be available for you. Also, Dr. Nusrat couldn't join us for any questions. If there are any, and we do have Alex Villarreal here that can answer. Unfortunately, Dr. Villarreal was called to an emergency, or Dr. Nusrat was called to an emergency in the hospital. So did we answer all the questions on home sleep apnea testing?
I don't see any questions here for home sleep apnea testing. So maybe we can move ahead and go with the door prizes, Marla.
That sounds wonderful to me. I want to give some stuff away. Again, thank you. Thank you so much for joining us for our first ever Wisconsin Sleep Society virtual conference. This was a wonderful day of learning for everyone. A couple of housekeeping items to add. All of the talks that you saw today will be available on demand, but please give us at least a week to 10 days to get them available to you. You will get an email when things are available, so you can go back and complete the credits that you weren't able to watch today. Don't email us until after October 1st. Give us at least until then to get everything organized and online for you. If you don't by October 1st receive direction how to watch the other videos and get your credits, then please reach out to us and we'll make sure you get those instructions. The certificates for CEU or CME will be coming from the AASM with email instructions on how to claim them. I want to thank our sponsors for helping us to put on this conference today. Also, all of our panelists and speakers, some wonderful information. I heard room 2 had a great day also. So there's lots of good presentations that we can reference even after today. And you can watch as many of them as you would like to, but you will only receive CME or CEU for the credits for the presentations that you do view. So that being said, we are going to go ahead and give away some door prizes. We have $50 Visa cards that we are going to give, and we thought it was only appropriate we give the first person who signed up for our first ever virtual conference a door prize. So Alex, you want to tell everybody who that is, who was the first person to sign and who is the winner of our first $50 gift card?
Absolutely. So we have Kellen O'Brien. Kellen O'Brien. And if you're not here, we'll make sure we send you an email to let you know and make sure you get your prize. So thank you for being proactive and being the first one here to enroll in this virtual conference. And as a follow-up, we thought we should talk about things that are related to our conference. So for those who are paying attention here, if someone could give us the first answer on who or when was REM behavior disorder first described. So if someone could type.
You can answer in the chat.
There you go. So I have Galaxy S20, 1986. Now, the person there with the moniker of Galaxy S20 Ultra, I think, 5G. I'm sorry, let's see. So it's 1986, and that was presented today by Ben Grafe. So, make sure you do contact us here
And claim your prize.
and claim your prize. Exactly.
Mhm.
Then another one was so what bird can sleep while flying?
Any guesses? What bird can sleep while flying for a $50 gift card? Type your answer in the chat.
So whoever Googles is the fastest, I guess. Okay.
Nobody wants $50.
So
We
we
got
we
some
got
answers.
yes. So we got the albatross, but
Alex,
is-
I think we have Alexis
Oh, right
Whaley
here.
for albatross. Alexis
Oh, there
Whaley
you go.
for albatross.
There you
excellent.
go.
So Alexis Bailey. Okay. Thank you. We'll make sure here. So got it. And so since this is again from Wisconsin, what is the Wisconsin state instrument?
I actually didn't know we had a state instrument before yesterday.
Accordion, exactly. I'm hearing it. So Rob Sonnenberg. So Rob Sonnenberg, accordion.
Dr. Sonnenberg.
Excellent. Okay. I have a lot of winners here. And see another Wisconsin trivia question. Where did the original cheese hat make its debut?
Oops, somebody got it.
Brewers. Okay, so Sarah
Sarah.
with an H. Please make sure you contact us, Sarah. So Brewers.
Dr. Villarreal, can we tell people don't go in the Q and answer part, the raise your hand part. Please go in the chat room to put your answer.
Yes,
So
please.
go in the chat room.
Yes, please, chat room.
And Sarah and all the other winners, please email us at our Wisconsin Sleep Society email, wisleep2013@gmail.com. Because we're going to deliver the gift cards by email. So send us your best email. Okay, I'm done. Sorry.
Excellent. So how many more cards do we have?
As many questions as we gave you.
Okay. Okay, so where did the sleep and circadian rhythm in human study to take place in 1938?
Where did it take place? What is
Yes.
the location?
Yes, sleep and circadian rhythms. Give you guys a clue, it was in the US.
Oh,
A
Okay,
cave.
a cave.
Somebody's
Which
close.
cave?
It was a cave.
which cave?
Kentucky, a cave in Kentucky. We're getting close. Yes.
Yeah, there you go,
Mammoth
Dave.
Cave. Dave, email us your last name.
Dave, Mammoth Cave. Excellent. Okay. So what kind of a dog breed was used to study cataplexy? Doberman.
Doberman.
Okay, so
Catherine
some
Loomis.
was too fast for me. So Kathy,
Kathy Loomis.
oh, Kathy Loomis. Oh,
Loomis.
oh,
Yeah.
Kathy,
Hi,
excellent.
Kathy.
Okay,
Hi, Kathy.
wonderful. Well, greetings to Kathy. Excellent. So, then let's see here. We have okay. Which member for the Wisconsin Sleep Society can do less push-ups on their elderly father?
Yep, there we go.
Hmm.
Patricia Kane.
That's right. There you go.
Patricia, email us your address, your email address.
Awesome. And well, let's do the last one, Marla. So,
Last one.
okay, yeah, I said that was one. So, and there's another one, which is which board member can't do more than one push-up? Clue, it's not me.
Yep, Todd Palmer. Todd Palmer.
I don't even know you, Todd Palmer. What do you know that I can't do one push-up?
That was fast, Todd. I don't
But
know.
you're correct.
Okay. Excellent.
Very good. And I want to thank my board. Our team has been amazing. Pull off this conference. The Wisconsin Sleep Society Board, like I said, we're all just hardworking sleep professionals, and a ton of work went into it. We hope to repeat next year. So always looking forward to fall for our Wisconsin Sleep Society conference. Thank you. Thank you very much for joining us, and have a wonderful day.
Yeah, thank you, everyone. Have a wonderful weekend. Bye-bye.
Bye.